if we start all young children on lopinavir, do they need to be on it lifelong? And the Neverest study randomized children to staying on lopinavir versus switching to nevirapine. And they saw that some children may be able to switch, provided that they have no NNRTI mutation before they start ART, and they have virologic suppression on lopinavir. So this brings up the question that then you need access to genotyping and also access to viral load in order to do this. So how about complications of HIV and its therapy? Pediatric treatment failure is what we all worry about, and in the Thai national guideline, the number of children on second line has increased from 4% in 2005 to 20% in 2010, and this is likely due to routine viral load monitoring capturing children earlier. The TAPOD regional cohort showed that 14% of children in our region are already on second line. So this brings up the question, so what to do if second line fails? And we do need new drugs, and out of these new drugs, only the darunavir is approved in children age 6 and above. And in our cohort in Thailand of 7 sites, we have about 40 patients now on darunavir traveline, and what is worrisome is that we're already seeing almost 20% virologic failure at 1 year, and we have little option for these children beyond third line. How about other complication? Neurocognition is very important. Children have growing brains, and if we start treatment too late, that may affect their IQ. Metabolic and bone complications are common. A recent study in Thailand showed that 20% of children on treatment have low bone mineral density. And lack of immunity is something sometimes we forget. And in a group of Thai children who got hepatitis B vaccination during infancy, we found that 10% of the infected children have immunity, and these children need re-immunization. So children and youth have to deal with many issues, and psychosocial support is an integral part of caring for children. It is equally important and probably more important than the medical component. They usually come from poor families. There's more than one person who's infected. Once you see a child that has infection, they have to deal with stigma, discrimination, significant stress. It's difficult to disclose HIV of the child's own diagnosis, the parent's diagnosis to the child. Many patients have lost their parents, and they have to be taken care by caregivers who may not want to take care of them, and these people may have poor attitude. Parents themselves may have poor parenting skills. In the Asian culture, oftentimes children have no say and adults are always right. So when they're young, they have no way out and nowhere to go. And we see when they reach teenage years, there's a lot of delinquency and sexual problems. I'd just like to bring up one psychosocial issue is retention in school, because if children are not in the formal school situation, this is a major obstacle to transitioning into the adult workforce. In our program, despite having psychosocial program support, 3 full-time social workers to help the children, we still see 14% of children that are not in the school system, and these children are at risk for poor adherence, for delinquency. So we're looking at possible interventions by involving caregivers, motivating children, bringing children who have success story, who've been in university, to motivate the other children, have support, have guidance from educational expert, and provide financial support. So what are the lessons learned from the region? We know that infants need immediate treatment. We have to make sure we can diagnose them early, have lopinavir, ritonavir to treat them. Older children may be a different story, and we have to look to see what is best for each family. And if we want to defer, we have to do frequent CD4 monitoring. Treatment failure, organ system involvement, we're already seeing this. These require monitoring and intervention, and psychosocial support is an integral part of pediatric care. So what happened to our children? The 3-month-old healthy girl was started on lopinavir. She did not have NNRTI mutation at the start of ART, and we will be switching her to nevirapine once she has about 6 months of virologic suppression. The 5-year-old boy had CD4 of 320 and 19%. Although he fits the initiation criteria for ART, his family situation was in chaos. It was unclear who would be the primary caregiver for him. we and the family elected deferred treatment. He's continuing to receive CD4 monitoring and he's doing well. The 12-year-old was picked up to have virologic failure from routine viral load monitoring. She gave perfect adherence history. It turned out that after her father died a year ago, her mother had to go back to work and work long hours and had little time for her. So once this was recognized, the family situation at the time that the mother needs to give to her was modified, and she's doing well on second-line treatment. So I'd like to acknowledge Dr. Annette Son, who helped tremendously with preparing the presentation. The other people here provided data. UNICEF and the We Understand group produced the video that I will show you next, and I thank the ICAP organizer for inviting me. So I would like to end my talk with a 3-minute clip from a production on Who Am I? Why am I here? These are voices of 4 Thai children with HIV, and they say it best what it is like to grow up with HIV.
ติดเพราะแม่ติดเพราะน้ำนมไม่คิดยังไงก็รักแม่เหมือนเดิมตอนป .6 ไม่สบายนอนโรงพยาบาลมันปวดหัวมากนอนโรงพยาบาลตอนนั้นนอนอยู่2 เดือนเจาะสันหลังอะค่ะให้ป้ายาเหลืองๆให้ทีละนิดๆให้ทุกวันตอนนั้นแม่ป่วยหนักครับแม่ก็ตายไล่ๆเรื่องกับพ่อพี่ก็เลยพาผมมาตรวจครับเป็นฝีในหัวครับปวดหัวมากเลยครับปวดแบบปวดมึบๆขึ้นมานอนก็นอนไม่หลับครับตอนผมป่วยผมไม่มีเรี่ยวไม่มีแรงเลยครับกลัวมันจะเป็นฝีครับบางครั้งก็ฝันว่าตัวเองจะตายอย่างนี้ครับมันกลัวครับ
แล้วทำยังไงเวลาฝันร้าย
ก็คิดว่าเป็นแค่ความฝันแล้วมันก็จะตื่นมาเองครับถ้าจะทำให้จิตใจเราโปร่งใสเราต้องไหว้พระก่อนนอนครับสวดอรหังสมานี่แหละครับเพื่อจะให้ตัวเองหลับอย่างสนิทสบายครับไม่ฝันเรื่องร้ายๆอะไรครับพ่อตายประมาณ3 ขวบแล้วก็แม่มาตายทีหลังตอนหนูประมาณ9 ขวบแล้วก็ตอนนั้นก็สุดกินยาประมาณ 6-7 เม็ดก็ยังกินนะไม่กลัวเราต้องสู้กับมันถ้าเราตายไปแล้วเราจะเกิดเป็นใครอะแล้วเราจะเป็นคนเดิมอีกไหมคิดอย่างเงี้ยแล้วก็เราก็ไม่อยากตายไงเพราะว่าชีวิตของเรามีครั้งเดียวตอนหน้าหนาวไม่อยากลุกมากินยาเลยเพราะว่ากำลังนอนแบบอุ่นมากนาฬิกาปลุกก็ไม่อยากจะลุกมันเป็นเรื่องที่น่าเบื่อมากเราต้องกินทุกวันแล้วก็ตรงเวลาถ้าใกล้จะถึงเวลาเราไปเล่นกับเพื่อนเนี่ยก็กลัวเพื่อนสงสัยเหมือนกันแต่ตอนนี้ก็ชินแล้วเป็นชีวิตประจำวันกินเพื่อไปต้านเชื้อไม่ให้เข้าไปทำลายร่างกายเรามากไม่คิดอยากจะเลิกแต่อยากจะคิดคนสูตรยาที่กินแล้วแบบกินเม็ดนึงแล้วนานได้1 เดือน 2 เดือนเนี่ยไม่ต้องกินบ่อย
Thank you very much for your attention.